I will be coordinating the session and introducing you. We will begin in a couple of minutes.
Yes, good morning. Good morning, everyone. You hear me?
Buonasera nella Italia.
Buonasera.
Hi, Mateo. How are you? This is Carmen. Thank you so much for being here. Thank you.
No, it is a pleasure. It's always a pleasure to collaborate with you.
Thank you so much.
Bueno, pues bienvenidos a todos de regreso y buenos días a los que, o buenas tardes a los que se acaban de conectar a esta segunda conferencia magistral que ocurre en el marco del segundo seminario interdisciplinario de investigación sobre envejecimiento que organiza el Instituto Nacional de Geriatría de México. Es la conferencia magistral que tenemos a continuación. Tiene un ponente que para la mayoría de ustedes no requiere una presentación adicional. El doctor Mateo Cesari es ampliamente conocido en el ámbito de investigación en geriatría, pero pues siempre vale la pena hacer una pequeña recapitulación. Él es médico de la Universidad Católica del Sagrado Corazón, de Sacro Cuore, en Roma, Italia. Ahí mismo hizo sus estudios de doctorado en medicina preventiva en las personas mayores y su fellow en geriatría. Y desde entonces, bueno, también desde el 2013 es profesor asociado de geriatría y desde 2017 profesor titular. Es investigador en el ámbito de envejecimiento y geriatría, asesor para la Organización Mundial de la Salud en temas de envejecimiento y condiciones asociadas al envejecimiento, profesor asociado de la Universidad degli Studi di Milano, la Universidad de Estudios de Milán, y director de la unidad de geriatría de la Fundación Cagranda en el Hospital Maggiore Policlínico de Milán, Italia, desde el año 2017. Es justamente desde esta posición que tuvo el extraño privilegio, si así podemos llamarlo, de encontrarse en el epicentro de Europa de la crisis mundial de COVID. Y justamente su presentación rondará sobre la situación de COVID en instituciones de cuidados a largo plazo en el mundo en general y una perspectiva de primera mano sobre su partecipazione. Quindi, professore Matteo Cesari, è un piacere averli con noi. Damos inicio alla sua presentazione.
Thanks a lot. I'm sorry I do not speak Spanish. I understand, so thanks a lot for the very nice presentation. I can share my screen so that you can hopefully see my slides. You see them?
Not yet, but now we're seeing it. Thank you very much.
Okay, so this is the title of my presentation. Of course, I work in Milan. Milan is in the Lombardy region, the northern part of Italy, which has been the epicenter of the pandemic here in Italy, and I would say in Europe, because this was the region that was first hit by the pandemics after China. And we have faced very hard times here in this region because of a large unpreparedness of the system in front of this kind of stress test for the healthcare system. And of course, as in most parts of the world, we have seen a real tragedy ongoing in the nursing home system, which is traditionally neglected and abandoned from the rest of the healthcare system. And when something so stressful as the COVID-19 arrived, we realized how many problems were in this setting. And from this experience, we are trying now to develop a new model of care to implement in this, I believe, critical node of the network, especially in countries that are experiencing a rapid aging of their population. So the first question, in order to face the problem on how to renew the nursing home system is how the SARS-CoV-2 got into the nursing homes. And of course, we cannot say that the COVID-19 was born in the nursing homes. It firstly came from outside. Of course, the local situation of the specific geographic area where the nursing home was placed played a critical role in explaining the consequences of the pandemic. There were nursing homes in the epicenter of the pandemics that, of course, were really decimated, were really emptied by the COVID-19 and paid the highest toll of death in their patients. Others in different regions were relatively spared despite the frail status of their residents. The infection, as I said, came from outside. So there was the territory, and there were the personnel of the nursing home, visitors, family members, external personnel. And here I'm thinking of the critical points that have been faced by nursing homes. Very often, at least here in Europe, the nursing home, there is a part of the nursing home personnel who works in the nursing home permanently, but there are other persons who work in different nursing homes. And so they played a role in disseminating the infection across the different facilities where they were working. Volunteers, of course, are another possible source of infection coming from outside. And at the very beginning of the pandemic, consider here in Italy that the pandemic started in mid-February. The first case here in Italy was the 20th of February. At the very beginning, we were really struggling to understand what was happening. And when the first wave hit the healthcare system, our emergency department were completely overwhelmed by acute patients with respiratory symptoms. And it was difficult to manage everything, and it was difficult to understand what to do. It was not yet sufficiently clear, despite the initial evidence, that the virus was so contagious. And one of the first solutions that was put in place by, for example, our regional government was to decrease the pressure of the emergency department by sending asymptomatic patients or patients that were very mild symptoms to the nursing homes in order to decrease the pressure that the emergency department were experiencing with this overwhelmed number of acute patients. And of course, sending a patient that is not adequately tested, only basing the absence of the virus on the symptoms and not on a formal testing with the PCR, well, that was like throwing a match into the barn. And there were some infections coming from the hospital in this context. And then there was the spread of the infection inside of the nursing home through the contacts, resident to resident, personal to resident, resident to personal, also considering that the infrastructures that have characterized nursing home over the years are developed in order to promote the exchanges, the contacts between family members and among patients. So the difficulty of isolating cases in the nursing home, partly also related to the delays that we're experiencing in this setting to understand what was going on, because the nursing home arrived late, and I will show you some slides about this. So this is a graph showing the situation in Italy today. As you can see from this slide, today in Italy we have roughly 2,000 new cases of COVID-19 per day. This number is surely much lower than what we experienced during the first wave. Also, the severity of the cases is extremely milder compared to the first wave. But I mean, the numbers are closely monitored because we are in this second wave right now. We are reopening schools. The life seems almost normal, of course, with all the social distancing, wearing masks, but COVID is out there. And as you can see from the map, it appears that the situation is relatively heterogeneous across the entire Italian peninsula. Nevertheless, sorry, if you go at this chart on the bottom of the slide, that it is describing the number of cases per week from the beginning of the pandemic up to today, region by region. You may realize that there are some regions, like the region Lombardy, the third one, that is a complete blue line, meaning that, I mean, we have had a lot of cases every week since the beginning of the problem. Whereas there are other regions that are very light blue, sometimes even white, also during the second wave, meaning that they have not really experienced the COVID-19 pandemic. That is, it is very likely that there is this geographical heterogeneous distribution of the COVID-19 that is something to be taken into account, because implying the need of a monitoring that may not be on the entire nation, systemic, on a large scale, but probably the monitoring and the testing should be as capillary as possible. To confirm this hypothesis, this is the same map, September 24, and this is the map at the end of the first wave, May 10th. And as you can see, at the end of the first wave, there were some regions at the bottom, in the southern part of Italy, that had never had really cases of COVID-19, and everything was concentrated in the northern part. So there is an heterogeneity in the dissemination of the COVID. The geographic area may play a role at explaining this phenomenon. And this implies the need of being very capillary, very detailed in the approach for preventing clusters and preventing the dissemination of the virus. This is something that is described as the Simpson Paradox. It is something that you need to consider, especially in large countries like in Mexico. It is something that has been observed, for example, in the US. This means that when there is a trend, you always need to consider the possibility of different subgroups of data that may potentially explain in a different way what you observe. In this graph, you can see that the black dots are showing a negative correlation, a decline, things are getting better. Whereas that negative trend is composed by many different positive trends. And you can see that things are wrong in a temporal sequence only if you have this more detailed approach able to discriminate the subgroups. This was seen, for example, in the US when they saw that there was a general stability of the new cases of COVID-19 without considering that there were different states with different rates of new cases that as a whole were showing a relatively positive trend, but in reality they were showing a lot of new states beginning to be infected by the COVID-19 in a very serious way. So this is something to consider. There is an unexpected onset of clusters. This is the problem, and we need to develop solutions in terms of contact tracing and regular and in-depth monitoring in order to face this pandemic. Another thing that is strongly involving the nursing homes is the relatively lack of information that usually arrives in this setting, and from these settings arrives to the general media. This is an article that was published on March 30th on one of the newspapers here in Italy. So after 1 month and a half from the first case, in this newspaper, there was this question: what is happening in nursing homes? Because it seems that there is an excess of mortality compared to standards. So, in other words, coming back to this figure that I was showing before, if we look at when the article was published, it was published here, March 30th, 1 month and a half, almost at the end of almost when we were at the peak. The peak in Italy, in my region, in the Lombardy region, occurred at the very beginning of April. I think to remember April 3rd. So we realized that there was a problem with the nursing homes only after 1 month and a half. Because why? Because nursing homes are too often not considered part of the healthcare system. These are settings where people goes to die in the public image. These are settings that are not very nice to see, and for which we tend to have a very feeble memory. We try to forget them too often. And these are the consequences, that information in this setting arrived too late when the virus was already there. And once the virus is in the nursing home, it is too late to prevent the consequences, the negative consequences that we have observed during these months. So the delayed interventions that have been put in place necessarily lead us to consider in the new long-term care setting that we have to develop after COVID-19 to improve the connection between the nursing homes and the rest of the system, and to develop an action plan that can be immediately activated in case of need. There was a delay in putting in place countermeasures that cannot be accepted anymore, because we have seen the nursing homes are hosting the frailest individuals, and we have to protect them as much as possible. And at the same time, we need to have a prompt communication with these settings that did not occur here in Italy, because everyone was looking at the healthcare setting of excellence, the hospital. So everyone was focused on the emergency departments, and we forgot about the rest of the healthcare system. And since the healthcare system is a network, as soon as there is a knot that is weak in the network will fail in its functioning. Which were the major issues that we need to consider as experience, and on the basis of this we need to build the new system? Well, this is a survey that was conducted in the month of May, so after the first wave, among a representative sample of nursing homes distributed across the Italian territory, especially in the northern part. So we are talking about nursing homes who really faced the COVID-19 pandemic. And when the medical directors of the nursing homes were asked to list the major issues the nursing home had faced during the COVID-19, this is the list of problems that, looking at the literature, are relatively common. I mean, first of all, the lack of PPIs, the personal protective equipment. At the very beginning, we had no masks to protect the healthcare personnel. So if the healthcare personnel was not falling sick, and we had a huge number of deaths among the healthcare professionals and sick leaves, the best option was that the personnel was becoming source of infection among residents. There was no access to PCR. Today we start having data describing nursing homes who get access to the testing after 1.5 months, 2 months from the first case. So at the very beginning, and consider that we were in February, where there was still flu around, there was cold weather, it was pretty much difficult to distinguish a cold from COVID, and it was impossible to really measure what was happening. And I do not talk here about what means identifying a person that is asymptomatic in this chaos that we were experiencing. At the same time, and this is something that I mentioned before, in the nursing homes, there are healthcare professionals that are not structured to work there. They are external consultants, they are persons who work in different settings and professionists without being a formal link, an exclusive link with one nursing home. Besides of disseminating potentially the virus across setting, as soon as there were more and more problems, some of these professionals decided to not show up at work, because, I mean, they were real professionals. They were not really focused on the mission of the physician. They were also, there were a lot of persons in sick leave, and this created a lot of problems, because automatically the shortage of personnel created more problems in the management of a very critical situation. And as I said, another problem was the difficult isolation of patients once that the cases were started to appear. I would here focus on the first line that is showing another problem we had and we need to consider. The first is lack of PPEs. In the following page of the report, after this graph was shown, and this figure is showing the answer to the question, has a training program on the correct use of PPEs been conducted at your nursing home? And the vast majority of the medical directors answering to the survey answered yes. So everyone was really ready and well prepared at the use of PPEs. The problem is that there were no PPEs. So it is the difference between the theory and the practice, the theory and real life. In theory, we were wonderfully performing. In practice, it was a catastrophe. This is something that we need to consider in the future because we need to avoid that the administration that is burdening very often the clinical routine of the nursing homes might be translated in something more practical. And besides of the paperwork, there are really all the devices that are needed for dealing with the emergencies like this. Besides of this, and we need to consider that the tests were not routinely available, and we know also that there were a lot of false negative results at the PCR, especially at the very beginning when there was really the first kind of test that were proposed. There was a fragile integration of care of nursing homes. The problem is nursing homes trying to send patients to the emergency room, but the emergency room declining to accept the patients or suggesting the nursing home personnel to avoid sending patients and to manage them locally because they were overwhelmed, because there was mainly nothing that they could do. We still have no treatment for COVID-19, and sending a person like this, with COVID-19, with suspect of COVID-19 to the emergency room might be detrimental for the same person waiting hours without being treated in a very risky environment. And at the same time, we as geriatricians have seen really the collapse of the geriatric medicine principles, because I mean, everything was chaotic, everything was done in emergency. And this, of course, put on a second stage, on a second level, the importance of dealing with critical conditions of older persons who might be seriously detrimental for their health, but were not seen. And so there is a lack of resources, infrastructural issues, the scattering information that can be solved in multiple ways, but mainly we need to organize the system, the future system, for a better integration of nursing homes in the healthcare setting, potentially also promoting the use of standardized assessments that can be centralized in databases that can be evaluated really immediately, very quickly, for identifying the first clusters and when things start to go wrong. The last point I would like to make is about one of the major issues that we have faced in Italy, I believe everywhere in the world. Is something that is there and we are struggling really a lot to fight against. That is the so-called ageism. At the very beginning of the pandemic, the Italian Society of Anesthesia published this report about the recommendations for the allocation of intensive care treatments in exceptional resource-limited circumstances. We were facing hard times. We were choosing patients to provide pulmonary intensive support, and we're deciding who should be abandoned. Now, in this document, the word age appears twice in 2 paragraphs. In the first paragraph, it is written an age limit for the admission to ICUs may ultimately need to be set. In the second line, they said, yes, age is important, but comorbidities and functional status should also be measured when taking these decisions. Which was the problem? That in an emergency, age is very easy to measure. And most of the physicians are not used to measure comorbidities and functional status. So this document, although was providing a suggestion to improve the evaluation of older persons, because was talking about comorbidities of functional status in the evaluation of the triage, something that is not very common in the traditional medicine. Still, this document was talking about age at the very first point, and decisions have been taken looking at the birth date of the patients in too many cases. So taking decisions that were obviously wrong. We should look at this document with a positive approach, I think, because the consequences were terrible, but there is still the optimistic way of looking at this, appreciating that another specialty is starting to talk the same language of geriatric medicine, of geriatricians, and is pointing at the importance of comorbidities and function in the evaluation of the health status of the individual. Of course, things were wrong because they were using words they potentially did not understand sufficiently, for which we are not yet as a system ready to measure. But still there is something there for us to work on. Everything is about integration of care, I think. I think we need to build a new system of nursing home without talking exclusively of the nursing homes, because otherwise we will continue working per silos. We need to start talking, as the WHO is recommending, in a more comprehensive and multidimensional way, identifying the nursing homes as part of the system and working in the connections between the nursing homes with the rest of the healthcare system. We should avoid to discuss about work, the nursing homes, turn the page, and then the hospital, turn the page, and then home care. Everything is part of the same system, and we need to work on the connections between all the different settings. So these are my conclusions. We need a better integration of care towards a less hospital-centered system. We need to improve the training and qualification of the personnel working in nursing homes, and also improve the nursing home infrastructure, especially if we will realize that the nursing homes may play a role in the event of a new emergency situation as the pandemics. We need to implement technologies. We are discovering them today, and we are looking one each other through a screen today. And we need, of course, to provide the nursing homes the legitimacy, the value they need by providing them the resources to adequately work. And at the same time, we need to build up a new way of looking at this system by fighting the ageism that is really permeating our society. Thanks a lot.
Thank you very much, Professor Cesari. As always, it is a great pleasure to attend to any one of your presentations, even if it's virtually and from a long distance, as the circumstances demand nowadays. I would first like to apologize on behalf of Dr. Luis Miguel Gutierrez, who wanted to be here today. Well, I mean here virtually today, but unfortunately he had to attend a different meeting and he was unable, but he sends his regards on his behalf. And
no, he is always busy, so please send hello to me from me.
I will. Again, it's been a pleasure. We have a couple of, well, several questions already. Let's start with them. Professor Cesari, some people think that nursing homes and long-term care institutions are on their way to disappearing. What do you think is the future of long-term care?
I think, I mean, I do not think so. I think we live in a world that is globally aging, and this means that we will deal more and more with chronic conditions rather than with acute conditions. So I think that we need to rethink the role of nursing homes. Potentially, we need potentially to have settings that are potentially more equipped with more clinical capacities compared to the traditional model. But we need to consider that a setting that is not the hospital, because the hospital is for a different kind of persons, but also a setting where the clinical complexity can be faced without leaving the problems to the territory, to the families, because the disabling conditions are those with which we will deal with in the next future. So I think we need to reshape them, but we need to promote all the advancements that have not been done over the past years. We are working with nursing home models that have not changed over the last 20 years. It's the same. So we need to have an evolution in the hospital care, but also in the nursing homes.
Absolutely. Thank you, Professor. Another question. The current pandemic has evidenced that public health is not able to respond efficiently anywhere. Which other lessons do you think that we can learn about this experience?
Well, it is true. Globally, it has been really a disaster. But there are also countries that have done really a good job. I have not the most updated numbers, but for example, in Singapore, there were really very, very few number of deaths in nursing homes, despite a relatively large population of nursing home residents. Why is that? Because in Singapore, they experienced the SARS some years ago, and they have put in place the system that we are discussing today. So the contact tracing, the ability to respond to a pandemic event very quickly. They closed the nursing homes as soon as the first case was isolated. So they have done a very good job at putting in place what we are seeing today. They had this first stress some years ago locally. They learned from that and they adapted their system. I think that we need to take this experience on a global scale and do the same. And this will be the opportunity for us to talk about a new way of thinking about nursing homes and long-term care. There is no audio.
I am sorry. Thank you for your reply. I got another question. Thank you for your lecture, Dr. Cesari. What strategies would you recommend to minimize the spread of COVID-19 in nursing homes generated by people with asymptomatic or presymptomatic infection?
In theory, the closing of the nursing home is the solution for limiting the entrance of the virus in the nursing home, and at the same time to preserve the possibility. You know that there. You need to consider the nursing home as more or less exposed to the virus, as divided from the rest of the territory by a membrane. So the permeability of the membrane is something that you need to consider will protect or not the dissemination of the virus in the nursing home. The more your membrane is full of holes, the easier will be the disaster that we have seen. So we need to, of course, close and limit as much as possible the sources of infection. But as people involved in geriatric medicine, we realize how hard this is for the residents and for the and for the families. We need to find alternative, looking at the good sense, look at thinking a very practical way. Technologies may help. In the testing is critical, so trying to test as much as possible even the mildest symptoms, isolating all the suspect cases, of course, masks, social distancing, hand hygiene. And at the same time, I think it is also important to devote some specific personnel to the care of the patients, avoiding that the personnel may be the spreading source across the entire facility, so dedicating the team to the specific area of the nursing home. It is not easy, but I mean, we need to deal with this problem that will be with us for the next month, I believe.
Thank you. And in this regard, what role do you think that random testing of residents and staff, even when asymptomatic, is? What do you think is the role of that practice?
Well, I mean, you know, we are in a field where we think we talk about our perceptions very often without evidence. And what I can say is that the second wave that we are living today is completely different from the first wave we had some months ago. So some months ago, perhaps I would have told you a different thing. And today I may say something that is not supported by evidence. Some months ago, the only way to clean and to avoid COVID-19 in our hospital unit, in the acute care unit, was by testing patients and personnel every other day. And that was, I mean, and we continued finding cases in asymptomatic persons very, very easily. Today, given the milder manifestation of the COVID-19, I still think that the regular testing of the personnel is still important. At the same time, I think that the capacity of the virus to contaminate and to spread around is weaker, and so we may perhaps reduce the number of testings but we need to consider that the COVID-19 can be spread or overspread by asymptomatic persons. So I think we always need to consider the possibility of testing in a very regular way, but perhaps we can do much more by wearing masks, taking all the precautions, also considering that I do not know how sustainable is a system testing twice per week, 3 times per week, every patient and every professional over the long term. Again, I have no evidence to support this, but I believe that the reason why the second wave in Italy is much milder in terms of clinical expression compared to the first one is because in Italy we have had a very serious, very strong lockdown, and people is strongly adhering to all the other preventive measures, masks, social distancing, and this may have reduced the viral charge that is disseminated by the potential asymptomatic or paucisymptomatic carriers.
Thank you very much. Another question is, you rightly noted improvements in different areas. Now, you rightly note that improvements in different areas are needed. Is there a sole agency in Italy that oversees regulation and standards of care and evaluation, and that would oversee the implementations of these improvements? I believe it's...
Well, I do not... Yeah, sorry.
Go ahead.
No, I don't want to enter in politics, but in Italy is a mess. One of the reasons why we had a very heterogeneous distribution of COVID-19 across Italy might also be due to the fact that the healthcare system in Italy is coordinated by the central government, but then every region acts with his own budget according to his own priorities and potentially fixing its own rules. So we have had potentially this scattered manifestation of COVID-19 because there was a very clear epicenter in a very specific region, but at the same time that region may have also taken the worst decisions in the entire system. I think that the central solution of locking down the country when things were really going bad has been the first sign of the central government, and likely it was the right thing to do.
All right. We're on time, but we still have some questions, Professor Cesar. Is it all right with you if we continue a couple of minutes?
No problem at all. No problem at all.
So the next question is, do you believe that we are at the beginning of a new era in which infectious diseases will be again intermingled with chronic diseases in shaping aging? Do we have to begin to develop novel pharmacological strategies to face infectious diseases or change our health systems point of view?
I think there is a paper in Lancet, a very recent paper in Lancet, I think in the current issue, written by Professor Orton, the editor-in-chief, and he talks about the syndemics. That is a term that also Professor Rodriguez Gutierrez Robledo published a few years ago. And he was talking about the syndemics of COVID-19 with other clinical conditions. And I think this is the way to go. I mean, it's something that in geriatric medicine are relatively used to, looking at the complexity. Probably we have to consider COVID-19 as another comorbidity we will face together with all the other ones. And we will have to develop, again, a new way of approaching complexity through the instruments that we have developed over the year, the comprehensive geriatric assessment, the personalization of care, the multidisciplinary approach. So I think that the rest of the world outside of geriatric is discovering the complexity. We are used to this kind of complexity. We have now a new problem to deal with, the COVID-19 that was not present 1 year ago, but it's just another problem on the table. It will potentially change our way of approaching patients to discuss among us, but at the same time, is just another problem that will fit in the complexity of aging of older persons, and will find solutions both hopefully in therapeutics, but also and especially in the modification of the behaviors and of infrastructures. So I think, yes, infectious disease were there. I don't know if the COVID-19 will be the what was the HIV 20, 30 years ago. But I mean, we are today used with the HIV. We have found solutions. We have dealing with the consequences of the long-term treatment of HIV. But I mean, it's simply another comorbidity. Hopefully, we will have the same for the COVID-19 in the next future.
Let's hope so. Another question is, thank you for your presentation. Are nursing homes aware of the impact that the lockdown has had on residents? Do you have specific strategies to reduce the impact of confinement on people residing in Italy?
Well, the nursing homes in Italy reopened very late because lack of trust with the rest of the system. As I said before, the virus came in many cases in the nursing home brought by patients that the emergency department sent to the nursing homes because they had no place to keep them. So when the nursing home, in support of the hospital, of the emergency department, find itself in trouble because of this favor, of this courtesy, well, they close them in a very serious way, and we are reopening the nursing homes. The nursing homes have started slowly reopening in July. Now, this has been terrible for the residents, but it was felt as a lower priority compared to the risk of having a new infection in settings that have been really devastated. This has brought some innovation in the nursing homes. Now in nursing homes, we start seeing technologies, we have started seeing potentially visitors coming back, family members coming back with all the precautions, but we have changed the infrastructure. So those places that were first devoted to promote exchanges have been structurally modified for maintaining the social distancing while still allowing the personal contact, or at least having the possibility to see the family members and the residents. But again, it's a matter of restructuring everything, potentially with the use of technologies, with with tablets, via video conferencing, but it is we are still in a very preliminary phase here, because, as I said, we do not trust too much at reopening and coming back to a relatively normal life.
Of course. I have two more questions. The first one is, the pandemic has had a significant impact on mental health, depression, stress, loneliness, isolation, both in family and health professionals. Particularly in the case of Mexico, it has been difficult to find healthcare personnel who are specialized in mental health care for long-term care institutions. What is the situation in Italy?
Well, when that was really, this is something that we are seeing today, because when the government, the central government, locked down the country, all the outpatient clinics were closed. So there was only the hospital, the nursing homes, those who were institutionalized or hospitalized. All the outpatients had no support. We had a lot of deaths in primary care, among primary care physicians who were unprepared in front of the pandemic. And so also that support that could be given to older persons with mental disorders was lost over the first month of the pandemic, and these persons really abandoned by the traditional care got worse over time, of course. And we are seeing now that we are reopening the outpatient clinics, the consequences of this isolation and this really abrupt interruption of the of care. There are data that we are developing right now that are showing really an accelerated aging of these persons over a few months, and when these persons did not die. So I think the situation is very similar between Mexico and Italy. We completely forgot about the need of regular care. When we have restarted, for example, we had two means for trying to address the high demand of outpatient care. The first one was to filter the high number of requests via technology. So in order to prioritize the assessment, we started to have a first contact via conference call, via telephone, in order to see whether which was the priority to be given to the patient and potentially prioritize others in worst condition. And this could be done also by conducting outpatient clinics via video conference. Of course, this can be done in some settings and in some specialties. For geriatric medicine, it's not very easy, and we always face the problem of having the technology at the home of the patient, because very often older persons we know are not so technological. But if the family members was there in support, this was something that has been helpful.
Thank you. And at last, this is a personal question from myself. I noticed that you presented a slide where you described what were the issues that nursing homes faced in a region at the beginning of the pandemic. How did you collect this information? Did you use like mail questionnaires or online interviews, or how did you get this information?
Which one? The graph?
It was a graph of horizontal bars where you synthesized the main issues being faced by nursing.
That was a survey. That was a survey conducted by the Italian National Institute of Health. And they had this network of nursing homes, and they provided, I mean, it was a network that was already existing to monitor care offered to dementia patient living in the nursing homes, and it was used to develop the regular survey that was conducted every year and was developed in order to understand the consequences of the COVID-19, understand how things were going there. We were at the very beginning of this phase 2 at that time, when the first wave was almost over, and there was no idea of what was going on. Really, just to close, I don't want to take too much time on this, but really the collection of those data was something really terrible for the operator. I mean, people calling the nursing home in order to understand what was going on and to receive a feedback about this survey, and listening on the other line, people crying. It was touching.
I can imagine. Well, I appreciate very, very much, Professor Cesari. It has been a great pleasure listening to your lecture. Again, as always, very, very interesting and very rich. I'm sure we all have learned something or a lot from this, and we all take lessons to think about and to improve our healthcare systems for older persons, particularly in long-term care facilities. I would like to have Dr. Carmen Garcia to close the session.
Yes, thank you, Raul. Well, thank you so much, Dr. Cesar. It has been really an honor to have you. I have to say that we always read your scientific papers and also your tweets with great interest, because you always make us pay attention to what is really important, really crucial in geriatrics and aging research. Thank you so much. We wish you all the best for you, your family, and Italy.
Thanks a lot. It has been a pleasure. Have a nice meeting, continuation of meeting. I'm going to dinner now.
Thank you.
Thank you very much.
Thank you. Bye-bye.
Thanks a lot. Bye.
Regresamos.
Sí, gracias. Bueno, a todas las demás personas que nos acompañan, gracias por estar aquí. Tenemos a continuación un receso un poquito más largo para poder hacer algún alimento o estirar las piernas. Y nos vemos nuevamente a las 3 de la tarde para las sesiones de presentaciones de alumnos. Les recuerdo que esta sesión tendrá 4 aulas simultáneas a las que pueden acceder en los vínculos respectivos en el programa en línea cuyo vínculo recibieron por correo electrónico. Tenemos presentaciones de diversa índole, así que seguramente encontrarán distintas que les resultarán interesantes.
Muy importante que los alumnos, en fin, escuchen los comentarios de los investigadores ya formados. Ojalá podamos contar con todos. A las 3 de la tarde, un poquito antes, conectarse estaría muy bien. Muchísimas gracias. Gracias, Raúl. Gracias.
Buenas tardes.
Buena tarde, provecho.
Nos vemos un ratito.